This is Brendan of the Brookbush Institute, and in this video we're going over static manual release of the subscapularis. Now, if you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed manual therapist. That is, in your state or region, it is legal for you to do manual techniques. That's chiropractors, athletic trainers, physical therapists, massage therapists, osteopaths. I'm sure I'm missing a couple, but if you are unsure, please look up the laws in your state. Personal trainers, this probably does not fall within your scope of practice, although you could use the palpation portion of this video in an educational setting to help you learn your anatomy. I'm going to have my friend Crystal come out. She's going to help me demonstrate this technique. Now, if I'm going to put my hands on Crystal, I'm going to do some sort of manual intervention. I'm going to be pretty sure that that manual technique is going to have an effect on either the symptoms she was complaining of or her performance, and the only way to get there is through assessment. So we're going to assume in Crystal's case that she came in with a little anterior shoulder pain from working out. It's most prevalent when she works out. That we did her overhead squat assessment and her arms fell forward. We did some goniometry and she had some restrictions in external rotation and flexion. Subscapularis will restrict flexion a little bit. And that even when I did my manual muscle test, she tested a little weakness in external rotation. And I know that overactivity of my subscapularis can reciprocally inhibit my infraspinatus and teres minor. So I got my good working hypothesis going. Now I just have to think about my protocol for manual techniques, and they basically all come down to palpate and compress. Now we do want to get a little bit more detailed than that. So if I first start off with how do I palpate the subscapularis? Well, my subscapularis is on the anterior face, the entire anterior face of my scapula. Right, so the portion of my scapula that is on my rib cage, I need to get my scapula out from under my rib cage. The way to do that, guys, is you're gonna pull them into protraction, and then if you take the shoulder into flexion, the scapula will generally upwardly rotate. You can mess around with a little abduction, see if that gets you a little better upward rotation. And now this, her axilla is showing, her armpit is showing, and if I take my thumb and I press straight down into her axilla with my thumb against her rib cage, I'll actually press through some soft tissue, press through some soft tissue, press through some soft tissue, but eventually I hit bone and I can feel it. That is the anterior face of her scapula, and I know if I'm on the anterior face of her scapula, I have to be on her subscapularis. Now, this whole portion here, this tissue that you can see my thumb disappear behind, is not her subscapularis. This tube of muscle is her latissimus dorsi, her teres major, her teres minor. I want to make sure I'm medial to that musculature. Alright, so make sure you're in between that border of muscle and the rib cage. Now the next things I need to think about, now that I know how to palpate my subscapularis, is where are my trigger points? The trigger points for my subscapularis are generally in the middle of the length of my scapula. So this is her inferior angle, and this is her glenoid fossa here. So if I press down right in the middle of that, usually there's some dense fascicles there. And then the other trigger point is usually right up near the glenoid fossa there and the superior fibers of the subscapularis. Which kind of brings us to our next point. I do need to also be aware of, are there any tissues around her subscapularis that I could offend or insult or injure with compression? And I have to think that her long thoracic nerve runs along the anterior face of her scapula. So if I get that burning, searing, tingling, I want to get off that. And usually I can move my thumb just medial or lateral and be off that tissue. As I get up into here, I definitely need to consider that my lymph nodes, my axillary artery, some of those other nerves coming off the brachial plexus as it passes out from underneath the pectoralis minor are up in there. So again, if there are any symptoms that are not that tenderness associated with trigger point compression, get off it, move around a little bit. Chances are all of these structures are like 1 millimeter, 2 millimeters wide. You should be able to move a little bit, get at that same trigger point without doing any compression or making the patient or client uncomfortable by compressing those tissues. So now we know how to palpate the subscapularis, we know where the trigger points are, we know where some of those other tissues are. I've mentioned in some of the other videos, the way we find the appropriate tissues is with these broad strokes. And the subscapularis is no different, other than we're just not going to take our thumb and run it from inferior angle all the way up into her armpit, because that's obviously going to be uncomfortable. We're going to take a lot of skin, a lot of soft tissue with us if we go from here to here. And this is pretty delicate tissue already. We really don't want to do anything to make this any more uncomfortable. So we're still going to go caudal to cranial with our strokes, but we're going to do little short strokes. Right, so you guys can see here, I can start at an inferior angle, do this little short stroke, see if I feel anything. No dense fascicles there, pick up my finger, go a little higher. No dense fascicles there, pick up my finger, move a little, oh, there we go. Now we've got some dense fascicles right there. Once I find those dense fascicles, I can then compress and hold for 30 to 120 seconds until I get a release, and then I can keep going looking for those other trigger points that are closer to the glenoid fossa. Now there is one other subscapular trigger point, but we need to get Crystal into a little different position here. I'm going to have you roll over and face me. It's actually closer to the vertebral border of her scapula, but like on the superior portion. Now what I wouldn't do is try to get underneath the scapula starting up here. Guys, little trick. Start at the triangle of oscillation. It's this little point medial to the inferior angle of the scapula where my rhomboids, lower traps, and my latissimus dorsi don't actually cover. So I can actually take my fingers like this and almost just push her scapula right over the top of my fingers. Now I'm underneath and I can do my searching without having to go straight through all of this tissue, which of course is our middle traps and rhomboids, and if you're on a muscular person, that's going to be really tough. But once I'm already underneath, then I can look for that trigger point and I can hold it for 30 to 120 seconds. Now the last thing that you need to think about, and this is very important, is what is your appropriate body position so that you are comfortable. And what I just showed you wasn't it, guys. I was leaning over. I don't want to be leaning over my patient and be using my hand strength. I want to be standing straight up and using my body weight to apply pressure. So I'm going to go ahead and have Crystal lay on her back. The way I would do this is, of course, I would be on the side that I was going to release. I would take her arm, pull her into protraction and flexion, and now I can use this hand, or I can even do this. However, just kind of hold my side there, and then I can control her shoulder, and I can even use my body. And then I can do that same stroking motion with this hand, and then when I need to apply pressure, this arm's straight, and I just lean forward. Same thing with the other technique. Rather than leaning across and pulling up like this, what I'm going to do is I'm going to have Crystal go ahead and turn and face the camera. And I'm going to control her shoulder this way and use this hand to get underneath her scapula. And then I can even basically just continue to use this shoulder to push her scapula over my fingers rather than using my fingers to dig. Next up, we'll do the close-up recap. Now for our close-up recap, I need to be able to get to the subscapularis. So the first thing I have to do is get the scapula out from underneath the rib cage. The way I'm going to do that is I'm going to go ahead and protract Crystal's scapula by pulling her arm up this way. And then this is the inferior angle of her scapula right here. If I take her arm into flexion and abduction, I can actually feel the inferior angle moving out this way. So as I do that, I'm actually taking her scapula and moving it under the back of her axilla here. To actually feel the subscapularis, my suggestion is start with your thumb against the rib cage and push straight down. This thickness of muscle, all right, this mass right here, this tube of muscle on the axillary border, this is not your subscapularis. This is lat, teres major, teres minor. So we want to get medial to that. The easiest thing to do is just start at the rib cage and press down. And if I press, I can actually feel bone at the bottom of this palpation. Now keep in mind, guys, we have that long thoracic nerve, we have the axillary artery, some of the other nerves off the brachial plexus and lymph nodes to consider here. If Crystal's feeling anything weird, tingling, burning, searing type pain, something that's just really, really uncomfortable and it doesn't seem to be related to like trigger point pressure, get off it. Remember, most of these structures are only a couple millimeters wide, so it should be easy enough to move your fingers around a little bit and still get at that trigger point without compressing that tissue. I'm going to use, starting again at the rib cage, pressing down, I'm going to use those caudal to cranial short strokes to investigate which fascicles of the subscapularis are the most dense, seem overactive, seem to give up a bit more resistance. And I can feel some right there, which doesn't surprise me because, as we explained in the earlier video, from inferior angle to glenoid fossa, about halfway between is a common site for a trigger point in the subscapularis, and then there's another one in the superior fibers of the subscapularis, deep inner armpit, close to her glenoid fossa there. That's the one we have to be really, really careful not to impinge on any of these other structures. But once again, short strokes, making sure I'm not taking too much skin with me. We don't want to make our clients and patients uncomfortable for no reason. All right, and we're going to hold for 30 to 120 seconds or until we get a release. There is, of course, the other subscapular point, which I'm going to have Crystal lay on her side here. I talked about that triangle of oscillation, and Crystal's so lean you can actually almost see this dent right here. If you guys can see that shadow, all right, that's where there is no muscle covering that area. That triangle of oscillation, it's a stethoscope term. You can put a stethoscope there and hear a little bit easier than trying to hear through muscle. But we're going to use it because it means less tissue to dig through. If I put my fingers on that triangle of oscillation, I can take my other hand, pull her back into retraction, and her scapula actually falls over the top of my fingers. I can then search through until I get about 2/3 the way up the vertebral border, and I actually do feel an increase in the density of those subscapular tissues. And I can hold until I get a release. So there you guys have it, static manual release of the subscapularis. Make sure before you put your hands on anybody that you have a good working hypothesis on why the subscapularis might be overactive, indicating a need for release technique, and the only way you're going to get there is assessment. So if you're not up on your assessment game, check out those videos, check out our courses, and bring your assessment game up. Make sure before you do this technique on a patient or client that you've had the chance to practice. Grab some of your colleagues, grab a mentor with good manual techniques, and go back and forth. Make sure they're doing the techniques on you so you know what it feels like or should feel like, and you're doing the technique on them so that they can give you some good feedback. There is no replacing live education and mentorship when it comes to manual techniques. I hope you guys enjoyed this video. Please feel free to leave your questions below. I'll make sure I answer them as quickly as possible. I look forward to hearing from you guys.